Carol Gorney. I'm the clinical educator for the University of Iowa, and this is Patrick Enking. He is also a clinical educator for Northern Arizona University. And we're going to be talking to you today about site development, a step-by-step process. We do want to make this kind of interactive and encourage you, if you have questions, comments, and that, please feel free to speak up so that we can address them as we go. Okay, so we're going to check this. Our objectives for today are for you to identify multiple ways to develop new clinical sites, to fulfill the ARC-PA requirements for those site monitoring and visits, to identify the responsibilities not only of the program but of the faculty and the preceptors as you develop new clinical sites, and then set up a process to be able to evaluate those sites to make sure that they provide adequate supervised clinical experiences. The background about this, we all know. It's no surprise to any of us that site development is one of the crucial rate-limiting steps. There's more programs. We're at 181. There's 60 or more in the pipeline. So finding new sites and actually setting them up well with good expectations from the get-go is very important. It tends to be, for a clinical educator for me, and I think for Patrick as well, one of the most time-consuming parts of my day to make sure the site is running smoothly, to make sure I have enough depth and breadth of sites that are going to provide adequate clinical experiences for my students and in the type of experiences that I want, in hands-on experiences, procedures, a wide variety of ages, illnesses, and things like that. Sites do not have to be equal or perfect, but they do need to be equitable by ARC-PA. So you need to show that you're providing some sort of reasonable education that's similar for all the students, no matter what sites they go to. And then we also do need to monitor those sites to make sure once we set them up and get them running that we are providing adequate evaluation that they continue to meet the needs of the program and the students. Just some definitions. I think sometimes a few of them are confused. Supervised clinical practical experiences is the ARC-PA term that's used for rotations, clerkships, clinical experiences, and most of the time you'll hear me call them rotations. Site visits is an in-person visit that you go to see the site, sometimes just to see the location, the number of rooms, to get things going originally. Frequently is done with a student visit, but not always. A site evaluation is a little bit different than a site visit. It's actually where there's some sort of formal evaluation of the site, and it can be done by many different methods, and we'll go over those, and it's to fulfill the ARC-PA standards. Sorry about the mic cutting in and out. Student visits. That's a visit that frequently is done in conjunction with a site visit, but not always. Some programs go visit their students every rotation, every time a student is there. It may be done to evaluate the student formally, summatively, but it's meant to see how that student interacts or works with either the preceptor, the patient, the staff. It's done particularly for a student evaluation. Student evaluations may include those student visits. They can also include many other things, your formative assessments, your summative assessments, your PBAs, your written exams. So there's many other ways to do student evaluations. The site development process, Patrick is going to talk about.
Thank you. Can you hear me okay? I may not. A mic. Oh, now I do, I guess. So, of course, this is a process that we thought about and is part of the Clinical Educator Handbook that's on the PAEA website. If you haven't, your program should have received one from the main office at one point. But so we wanted to go through some of the steps here in terms of how to do site development. And some of you who have been around for a while may say, well, you know, that sounds great. It may not be the exact way that you do it, but of course every program does things differently. So we're going to go through all of these different steps. I'm not going to read them because I'm sure that you can read them, and we're going to go ahead and cover them anyway. So one of the tables that we created in the handbook was really about the different kinds of methods. Now, we were all trained as clinicians, not salespeople necessarily. And so there's a certain amount of sales that you have to have when you're a clinical educator in terms of site development. And so you usually want your warm calls, but you can have cold calls. I've walked into a clinic and just off the cuff met internist who said, well, nobody's asked me to precept, and sure, I'd love to have your students. I'll take one every rotation. That happened within the last 6 months. And so you never know when this kind of thing is going to happen, but you got to, you know, for the most part, you should prepare. That was an unprepared cold call. So there are the cold call methods. There's reaching out to your alumni. Now, we did a national survey. The PAEA sent out the survey to 83,000 practicing PAs, and we got almost 13,000 responses. And so some of the answers that we got was, I'm an alumni and I've never been asked. So look at your alumni. That's a great resource. What other programs within your institution have students placed somewhere and there's an affiliation agreement already in place? It may even cover your whole college, but you haven't asked if PAs can go there. So that's another resource to go through your affiliation agreements and say, oh, wow, I didn't know we had one at Scottsdale Health. Maybe they would take some PA students. So your AHECs. The AHECs, if you don't know, are in a federally and state-funded organization that will help you support your students in their rotations. They also help OT, PT, medical students, and they may identify housing or community resources. Sometimes they offset the housing costs. They're all independent in the way that they do things and what their mission is. But they're a great resource because they know the communities and they know where people might be interested in having students. PA networking through all of, one thing that would be great if, and we're all starting to talk a little bit more about that, is collaborating among programs. If you have an excess of sites somewhere, do you want to share that with others? That type of thing. But also throughout your network, like your state associations and things like that. Physician networking, sort of the same ideas. Students can identify sites. Maybe they came in and this is their second career and they had been at another institution as a respiratory therapist, and they knew some of the physicians or the PAs or the NPs there, and they thought that they might be able to get a nice clinical rotation. Then you could set up a process where they could recommend that you contact them. You wouldn't have them contacting them. You take control over that, and then you see if there's an interest there, and that's been a great way to develop sites through the students' past experiences and connections. Conferences, mailings, and presentations. So they all have their pros and cons. One thing I would say about this before you even contact the site or the preceptor is start thinking about who you're going to be talking to. What's the size of the organization? What's the mission of the organization? Does it seem to fit with your mission? What types of things are they looking for? Now the hot topics are they want to recruit. So now there are major organizations like Andrew Morris Singer was saying that get it, that are starting to say, okay, PAs are going to fill that niche that we have. You know, we have a shortage of physicians. We need nurse practitioners. We need PAs. We want to associate with a program and offer them clinical training so that they can recruit. This is huge right now. They're all looking at as they're creating ACOs and want to do the patient-centered medical home, they're saying, okay, PAs can be one of our answers. How do we start figuring out who we want to hire down the line? And it's going to be in a shorter timeline than it will be with some of the medical students. So before you can go to their website, look at if you think that you're going to go to a particular, say, community health center, do they have all nurse practitioners there? Are they training nurse practitioners now? Is PA going to be kind of more difficult to get into that clinic? So you can find a lot of information out by being a PA-PI. That's what I say. I'm a private investigator. So I'm looking up all this information is on hospital websites and health centers. Who the clinicians are, where they graduated from. So then you might find an alumni from Wisconsin and Arizona, and I'd say, hey, I'm a Badger, so, you know, hey, do you take students? You know, so you make some kind of a connection. There's that whole part of it, too, making connections with people. it's really, when I first started as a clinical coordinator, I always felt like I was coming from a deficit. I need sites, I need sites. Now we're coming from a place of strength, I think. We're coming from a place of strength because PAs are very much needed in this healthcare system. So we need to stop thinking deficit thinking. We need to start thinking we're adding value to your practice. We're going to be money-making machines coming in because you can bill for our services as well. So start thinking of those positive attributes that we have to offer them. And it's not always about money, as you'll see in some of our slides. So before you go, you want to find out a little bit more about them. If you know anybody in the community who might know the preceptor or know the organization, you might find out what's their motivation for taking a student. What would be incentives and barriers? So when we did our survey, these are some of the results, and you may have already seen this. It was released in JPAE this summer, and this is also in the Clinical Educator Handbook. So what we found, I'm just going to go over the top 5 there, but the altruistic motivations for people, these are PAs. These are only PAs that were surveyed. So we really find out that they want to keep up to date, that teaching is rewarding, and they want to give back to the profession. What a great internal, intrinsic motivating factor. So how do we tap into that when they have other things going on that may be challenging, when the preceptors have challenges? They want Category 1 CME. Well, that's just come on board. That was something that our committee worked on, and it's great that we can offer that to preceptors now. Support from the supervising physician. That sometimes takes a little work. Sometimes it takes education around how to integrate your student into the office without creating a long wait time. How do you stagger the patient visits? How do you do the 1-minute preceptor model and just kind of work it into your practice? There's things like that that we can offer as support. But we need to kind of know what are some of the things that they need from us as well. Support from the PA program. These other things are more, reduced cost, but financial compensation. I just wanted to point that out. 31% said that's an incentive to precepting. That's pretty interesting, isn't it? Anyway. The barriers: lack of support from the supervising physician, the administrators, or administrative and regulatory concerns. So I find down in Arizona now, I'm going into places that are very nurse practitioner friendly because they still have a belief that the PA needs to be supervised in the same building, or they need to sign their notes, that there's this really awesome supervisory relationship that is kind of, they don't want to get involved in that. And nurse practitioners, they can do this independent. It's easy. So what we're finding is that really I have to educate them in how to utilize PAs and what PA supervision really means in our state. So every state is a little different. So you need to know that, and you need to be able to address that concern. You always want to ask about concerns so that they can, you can find out. I think, as they say, you have 2 ears and 1 mouth. It's always good to ask those questions and kind of find out what are those barriers, what is the lack of support. If it's a lack of support, what's behind that? What is causing the issue, and then how can you address it? So being prepared with some of this knowledge of the things that people might be looking for, the conditions that might be causing a challenge, is going to be really important for you to be successful. So we're really looking for the equivalent means of evaluating. This is basically saying, okay, you should have a policy, you should have something in writing that this is how we're going to do things. This is how often we expect that we're going to visit a site. This is who's going to be doing the site visit, how many times they're going to be visited, how does the visit occur. As an earlier slide said, typically it's in person, but and I used to, when I was in New England, I basically did travel all over the country and meet preceptors. And I think by doing that, what I did was I established a relationship with the people in Minnesota so that when I had more people who wanted to go back to Minnesota, I already had sites there. I already had relationships with people that I could just call them up and say, Dr. So-and-so or PA so-and-so, I've got a student who's from St. Paul and wants to do rotation out in your area. Would you be willing to do that? And what I ended up doing was having sites all over the country. And I actually had one student at one point who just kind of zigzagged across the country because he wanted to live in Bend, Oregon, and just zigzagged, you know, and stopped and did 2 rotations here. But I had visited all those rotations. I had relationships with them. I knew that they were great preceptors because I had had that history with them. So, I mean, there's all kinds of things you can do to think out of the box. Does the program have the means to carry this out? That's especially important right now with new programs as they're developing. They're really looking at the clinical year and really trying to find out, do you have those resources? Are you getting the support? Especially with so many programs in one area, you really need to be very organized and really have established those relationships before your visit takes place, so that you're very clear that you have enough training sites. Does the program have the means to carry it out, especially if you're doing visits away? If I had to fly to Hawaii, are they going to pay for my trip to Hawaii? Yes, they are. Right? My program won't. But, and then what will be done in the event of a complaint or an adverse event? So this stuff, if you just have a nice policy written like this, and somebody comes and says, if you're having this, this, and this, how are you going to do that? You can be very clear about what your process is. So you're doing data collection, right? Oh, no, this is, okay, I'm sorry, you're going to do them. Okay, so part of what you need to do is collect data on the site. You need to know these, at least all of this. What I end up doing is asking them what their teaching style is, what kind of experience they've had, what do they need from me in terms of preceptor development, resources, what do we need to talk, and they can check all this off. It's a 3-page form that I have, but everybody has something different. Everybody gets their information differently. But what you want to know is the demographics and how many patients there are and what kind of experiences they're going to have, right? So, I mean, that's pretty self-explanatory, I think, to a certain degree. All right. Any questions at all or any comments? Just want to check in with you. Yes? Mm-hmm. It's in the Clinical Educator Handbook, too. But it's a process of having a 1-minute interaction out in the hallway, sort of like, well, what do you have? What do you think is going on? What do you want to do about it? And giving good feedback or a little bit, this might be a different approach, that type of thing. So it's a very short encounter, which doesn't take up a 5-minute or 10-minute teaching session. So it's a really nice resource. There was actually a nice presentation this morning. We're just starting that process. There's a...
So you can now officially register PA programs and register with AAPA and submit an application for $200 a year to provide Category 1 CME to PA preceptors that are precepting PA students, with the hope that soon it will expand to other disciplines.
Yes, and it's only for PAs right now. Yes. So it's AAPA. So if we can align ourselves with other entities that could give us credentialing for nurse practitioners and MDs and DOs, then we'll work on that. It's a good first step, though. Basically, about the preceptor, you want to be able to verify the credentials. That's very important. You want to be able to know what their prior teaching experiences, so then you can kind of anticipate what they're going to need for support from you. So these are some of the questions that might be asked in terms of getting the data. So the site evaluation, some people will do this Well, what they do is they'll take the data that they got from the profile and about the preceptor, and you should have a policy or a procedure of what you think a quality preceptor is going to be and what you think a quality site is going to be. For the most part, there's a lot of components to that. There's also information that you get anecdotally from other practitioners. There's all types of stuff that you can pull in, but for the most part, you should have that policy and a way of evaluating that preceptor and site and saying, okay, this is going to be okay. In this article, it was basically being very clear about what Duke University's approach to the process is. And so it's not this short, but this is pretty much what they're saying, is that we will visit the site every 2 years or more if a problem arises, and that they have the pre-printed evaluation form, and the same information is collected no matter who the person is, so that's more equitable. Methods of evaluation, this is too big of a slide. Again, this is in the Clinical Education Handbook. Basically, the different types of ways that you can evaluate. What you want to do is you want to get the data in person or through a series of questions that you don't get from the other forms. What I do is I'll go there and, how many rooms are there? Is there a procedure room? Do they have labs on board? Do they have x-ray? Are they on call? Is there an on-call room? Is there grand rounds? So you want to look at the whole picture of what this experience is going to be like for your student. And by obtaining that information, you really kind of say, okay, this is really a very rural site. They're going to do everything they can to stabilize people because they're 2 hours away from a medical center. So there's going to be a lot of really good hands-on activity in this site. This is a major medical center. It's an ICU. There'll be a team of a medical student, a PA student, a pharmacy student, and they'll be doing rounds in the morning, and this student will have 3 patients that they'll monitor throughout the day. So you really want to have a picture of what this is going to be like, because when you're starting to think about assignments, you need to make sure that people are having the right assignments in the right areas, right? So we're all kind of mixing and matching and saying, okay, here's an inpatient experience, here's an ambulatory experience. So it really helps for you to know that in as many ways as you can obtain information, then the better off you are. So these are some of the things that I look at too. Housing is one of the, we don't necessarily provide housing, but I want to go to the housing site. If we have something that's on a regular basis, say it's a community member offering housing, I want to see what that looks like. Unfortunately, I had a couple of incidences up in northern Maine that were, they were trailers back behind somebody's house, and, that's just not acceptable. You don't want to put anybody in an unsafe place. You don't want to put anybody in a place where they're just going to be nervous the whole time that they're there. You want to be able to create the best learning environment possible. So really, by going to that site, for me, I get to see a lot of these things. Is there adequate spacing? Is the student going to have their own space? Are they used to having learners in that facility? Is there EHR, and do they have access to that? Is there an orientation setup? That I want everybody to have an orientation. Is it an overall supportive living environment? And so that's all included in our site evaluation. And then preceptor orientation is going to be really important because they are going to be with the preceptor most of the time, right? So we want them to be self-directed adult learners, but we also want the preceptor to know how to offer experiences, how to offer extra information, how to evaluate the student and see what their needs might be. So a student in the first or second rotation is going to be different than having a student in their 8th rotation. So they can think about how they might change the experience a little bit for somebody who's got a little more rotations under their belt. Obviously, we give them the contact information. We go over how to provide specific feedback, not just, you're doing a great job. But we want them to be, I really enjoyed reading your note. It was very precise. It was legible, and you covered all of the areas that we needed. Or, I noticed in your review of systems that you were missing these couple of components. I think that would have been important to include. So we want them to be very specific and give continuous feedback. And then any processing for incentives or adjunct faculty status, things like that. The expectations of the program is huge. I have a sheet with just basically it's 40 hours a week. I expect you to be giving them ongoing feedback, to fill out the evaluation form on time, and all that type of stuff. So, any questions about any of that? Any comments? Okay.
So I'm going to recap just a couple things that Patrick mentioned. As you looked at the barriers and incentives, I think administrative support is really high. It was the 5th highest, with over 50% of people wanting support from the program. And when you looked at barriers to why people quit precepting or are not considering increasing the number of students or ever taking students at all from PAs that have never precepted, it's from word of mouth from programs not providing enough support. So as a clinical educator, sometimes when you get really short in a site, it's like, oh my God, they're alive, they're breathing, they're going to take a student, here you go. But I think with the amount of students, the quality students, the programs, that's just not enough. We have to do our homework. We have to make sure these are good preceptors, and not every clinician is a good preceptor. They all have the potential to do that if they're interested in it, but it really falls back on us as clinical educators and programs to provide them that support so they don't feel like they're out there on their own without any kind of support or anything to keep them afloat. So when you do part of that data collection, have you ever taught? What's your comfort level in teaching? Have you ever provided feedback? You're doing fine isn't the best feedback for the students. It needs to be, you did this okay, but I want you to work on this. What else would you think about? How can we do this? Telling them what kind of hands-on experience. So that's part of the data collection and the support that I think is really important, doing a needs assessment with them, using the information you know when you visit them. What is important to you? Do you want category CME, category 1 CME? You're busy, you don't have time to go to conferences. Do you want adjunct faculty? Do you want me to make a visit and hand your certificate appreciation to your office manager and tell them what a good job you're doing? I'm in an academic institution. That's great. When I send a certificate appreciation to a physician that's taken lots of students, I send that duplicate to the head of the department and say, your doc has done a great job with my students. I think it's amazing. That goes in their promotion portfolio. So you can do needs assessment and support and make them feel like they're appreciated, and they've also seen your face. And I think for the most part it's harder for them to say no. It's a little easier for them to say yes when something's fallen apart. And as you're getting that site going, you can make that connection, build on something. And then when you have all that data, kind of get the final approval, like, okay, I think I've provided them enough of my expectations. I know what they're capable of. I know when I'm going to need to go back. I know I'm going to need to see they're never comfortable giving feedback, how that went. Check in with them after a few students, make sure it's doing well, and just build that process and keep those rotations going. You don't want to go to all this work, get one student, not check up on them, and then they're like, well, I didn't hear from you after that student, so I'm never taking any more again. It's a process, it's some relationships, and some building of some teamwork there, and I think it goes a long way, and it helps us work better together. There's lots of different ways to monitor the site. Once we have the site, we're going to get a student in there again. That's great. They're going to take more than one. We get to come back. Do we want to do visits? I differentiate visits and evaluations. I have a policy in my institution that says every so many months I need to visit every site. I have a formal form I fill out. But then I have other sites that I'm just getting going, that I just stop by and say, hey, how's it going? Do you need anything? Did you still have that copy of your preceptor handbook, or did you lose it, or is it lost in your email? How are things going with the student? I check on a student. I bring them their certificates. So I just make my face known in sites that I really want to develop and work more, or in sites that are crucial. In my neck of the woods, internal medicine is very short. My internal medicine doctors get emails from me all the time. Hey, saw you published an article. Hey, saw you did this. Hey, just came by to say hello, to keep my face out there and let them know their support, so that I can continue to kind of nurture those relationships and make sure that they know I'm there and I'm going to support them. My program will not pay to go to Hawaii either. I'm very disappointed in that. So I Skype a lot of places. In places that I may only going to be used once or twice for a student, I'll Skype them. I'll ask them to carry their Apple around the clinic. Can I see your exam rooms? Can I see this? Can I see your office manager's face? There's a way to use technology to save some time. I don't always have time to run to Minnesota or Arizona or things like that. So you can use some other methods, emails, phone calls, to get those evaluation forms filled out. And then I just wanted to touch bases on logging. How many of you guys are having your students log? Everybody's logging. Does anybody use logging to evaluate your site? Okay. So there's some things we're doing differently. As we do patient logging, we monitor our student activities with that logging. We evaluate the competency. We compare our sites. And that's really how we do some site evaluation, is comparing those sites and looking at minimum numbers there in the different sites to show that there's some equity, not equality, but equity among sites, and that the variety of experiences we give to our students, though they don't go to the identical sites, they go to sites that are going to provide them an equitable education to all of our students, and that's kind of key. So I'll make a disclosure. I log with eValue. That doesn't mean you should log with eValue. eValue did not pay me. It's just the system I know and I use. So I've set up some groups and some reports, so I have some snapshots there. But you can do this with any of the systems. There's T-Rex, there's a MedHub, a Resident Hub, Typhon. There's all sorts of systems that you can use to log. You can have homegrown ones. But in some of the bigger systems, there's really some great, nice ways to collect data and data dump and look at your students and your sites and many things that you need for your ARC visit. These are things that I compare in my system for my students. I look at the number of patients they see, the age of the patients they see, the types of diagnoses, the types of procedures, the age distribution of the patients that they see, where they see them, and their ethnicity to compare things across the whole career. So I'm going to explain these because I kind of cut these snippets out so that I didn't show students' names or things like that. So in my system, I set up some groups. I set up a family practice group, an internal medicine group, and an emergency medicine group, and I put just those sites in there. So I have a group of family practice sites. Every preceptor in family practice that takes one of my students is in this group, and I can run a report on anything I want. Age, gender, all sorts of things. So this is a snippet of 2 rotations. Some rotations had 1 student. Some of the rotations had 2 students. They were each 4 weeks, and I looked at the gender. If my students go to all these different sites, these 15 different sites, are they kind of seeing an equal mix of male and female, or are they going to a site where they only see male patients? You know, I need them to see both female and male patients. And they're not perfect, they're not equal, but there's a nice blend in these 15 different sites, and this is just a very small snippet of 2 months. And so it's a nice way to compare, knowing that these 15 sites that I sent 20 students to, I'm getting a pretty reasonable gender distribution, that they're getting an adequate education in regards to that. So then I look by setting. Family practice, for the most part, is an outpatient and a clinic, and I'm not sure why I have both outpatient and clinic setting, but I do. There's outpatient surgery. I look at what setting this same group of students were in when they were at different sites. And this is not by student, this is by family practice site. So it's by a specific site, and there may have been 1 or 2 students there over 8 weeks. And there's kind of a nice even distribution. A couple of them get to go to a nursing home, a couple of them got to go to the OR. But for the most part, they're seeing a couple inpatients, and they're in an outpatient setting. They're getting plenty of ambulatory care experience. So I can compare by that mix as well. I look at age. It's very important to make sure that my students are seeing patients across the lifespan. So just in family practice, so this doesn't take peds or anything else, this is just how old are the people you're seeing in family practice, what's going on over the last 2 months. And I also, again, they're not perfect, but I could get a nice bell curve out of this. We see a few little bitty kids, a lot of pediatrics, more adults, a few elderly, and then a couple extreme elderly. And there's a nice bell curve there, and I can compare my sites. These aren't all of my sites, but these are the sites that have taken them in the last couple months, and I can look and compare and think, okay, student number 1 is getting a similar experience as student number 24, even though one went to Des Moines and one went to Arizona. I'm still getting a nice distribution of the types of encounters I want my students to have. You can pick in any of these systems the things you need to look at. I, coincidentally, have picked the things that ARC wants me to look at: age, gender, lifespan, settings, things like that, so that I can look at it and prove I'm providing equitable experiences for them. Here's an even smaller snippet. I just picked like 1 day's worth of logging for a couple diagnoses. We have certain diagnoses that we put on there because I want to know that what types of experiences my students are seeing. So I cut just a little snippet out of the middle to look at some important diagnoses. On this day, what patients did you see? So I picked, 6 students and look at the diagnosis they saw in internal medicine to just get an idea. And these reports can be ran in many different fashions. At the end of the year, then, I will collate it, and I will look at the students' experiences as a whole. I'll look at age by every single setting. I'll look at gender by every single setting. I'll look at number of patient encounters by every single setting. I'll compare family practice to family practice, internal medicine to internal medicine, so I can look at, A, my core requirements and to make sure they're balanced across the span. And then I can look at my students' entire education to say, gosh, when you were in family practice, you did not see as many kids, but then the peds you went to, you saw twice as many kids. So in the end, it's all a wash. You all got to see 300 patients. You got to see this many experiences. And I can monitor my sites by this as well to show that they're getting quality experience in sufficient number and depth to prove that they're competent. So I think that's really important. We still use the traditional things. My students evaluate the preceptor, they evaluate the site, they have summative exams, they have formative exams, they have PBA. There's a lot of different things that go into that. But this in particular, in using the student logging, helps me in a different way to evaluate the site. Because it's easy to walk in and say, what kind of patients do you see? I don't like to ask them to print their millions of things or come up with their most common diagnoses and things like that. So you can get a general gestalt of that, but then you can double check it on a yearly basis to make sure they are actually seeing those variety of patients and diagnosis and settings. And I think those are our references. Questions? So we require our students to only log 1 day per week. We do not make them log all the time. We had some method to some madness in coming up with some minimum diagnoses and minimum numbers. There's more madness to the numbers and more method to the diagnoses and procedures. We did a lit search to look at the most commonly seen diagnosis in family practice and primary care, because we're a primary care program, and reviewed the nation and the most common diagnosis done by primary care providers in the United States in the last decade, and picked the most common 30 to 40 procedures and diagnoses, and then the basics that we thought would be important, and included that in our logging. So we don't have minimums on everything.
What do you do to ensure the validity of the data because of it primarily being self-reported? And therefore not verifiable?
Well, you can verify it. I mean, there are ways in the system if you want to make the preceptor actually confirm it. We have not gone to that length. We have not set minimum numbers. We have just required 1 day of logging. They log once per week to give us a random sample, to give us a distribution. We don't allow cherry picking or things like that. They just do 1 day at one time. I hate to say I'm like the mom that checks on things. It's date stamped when it was logged the date and when it was put in and things like that. And so if it's off substantially, my system is locked down that it won't let them log a week later so that they're doing it on task. And I give them, we limit just a few things they need to do. It's a click box of 10 things to make it quite quick and easy for them. So I can't say that we guarantee it, but by simplifying the process and not overburdening them with numbers that I would love to have more of, I feel like we do still get an adequate distribution of the data that we need.
There will be times when you see that people do not meet the minimums, either procedurally or diagnoses. What's your remediation plan, and will you use simulation in that environment? Because we certainly know within GME that within certain specialties they'll view simulation as equivalent to an actual live patient.
So we review these loggings actually on a monthly basis. We review them quarterly with the students and assess their progress. And then several months before they graduate, we also look at those. And for certain things that have minimums like pelvics and women's health, if you've done your women's health and your minimum is not done, we actually pull them and move them to other clinics. We also do incorporate simulations. Let's see here, I'm blanking on it. The American Geriatric Education Association has a great set of modules online that are computer-based that you work through whole cases for geriatric, the most common 12 diagnoses for geriatric patients. So we add those to our internal medicine. In our pediatrics, we require them to log a day a week, but also realize that pediatrics is one of those things that's very seasonal. If you see pediatrics in January, you're likely not to get as many well children. They're going to be all RSV, flu, cold, things like that. And if you go in August, you're going to get all the kindergarten and physicals. So we've added the CLIPS cases through family medicine and actually require them to work through 16 to 20 modules there. So we incorporate them in some of them, particularly in areas where we think it will be more seasonal depending on when they go to that site. And then follow the logging to make sure if there's one student that's just not working as quickly, not seeing as many patients, not getting as many diagnoses, what do we need to do? Do we need to add more time, add more rotation? It does aid in the remediation process, I think. Do you have anything to say on that, Patrick? Mm-hmm. Other questions? All right, well, thank you for your time and enjoy the afternoon.